Transition our discussion on obstetrics here to the postpartum period. And the postpartum period has various definitions. Now, everybody agrees that the postpartum period starts once the baby is delivered. However, there's some disagreement on when that period actually ends. And the reason is it really just depends on where you want to set the goalposts. The woman's body is undergoing various changes and sort of reassuming her pre-pregnant state, but it may be several weeks before she hits her period when she starts resuming ovulation. Do we define the end of the postpartum period then? Do we define the end of the postpartum period as when her uterus resumes its normal size? It really just depends on who you talk to. So for our purposes, we are going to define the postpartum period relatively loosely. Okay, but you'll talk to different OBs, you may read different textbooks, and you'll find various definitions. At the very least, the postpartum period lasts 8 weeks for obstetric-related purposes. If you read the DSM-5, you'll see that for postpartum onset of depression, it's got to occur within 4 weeks. So you can see just a wide variety of definitions of when the postpartum period actually ends. We're going to talk about postpartum care. So all of these things occur relatively soon after delivery. We're going to talk about routine care, some of the common things that may go wrong, some of the questions that the mother may have for you, and some of the things that you'll want to educate her about before she leaves the hospital and when she comes in for her first postpartum visit. If you haven't already, please consider subscribing to my Patreon page at www.patreon.com/pwbmd. You can click on the I button on the upper right-hand corner of the video or on the link below in the description, and that should link you up. If you could consider chipping in $1 a month, a little bit goes a long way to help keep these videos free. If you subscribe, you'll have access to some of my premium videos in which I do case studies and provide workups for those patients, and that can help you with approaching the Step 3 clinical case scenarios, which are a challenge to a lot of people. So thank you for your consideration in advance. So we're going to talk about routine postpartum management, and that is basically what we do for a woman after she delivers. We're making sure that we're staying attentive to her health because there are still some obstetric things that can go wrong after delivery. We're also going to talk about some of the normal findings and complaints. They're not always necessarily normal, but they're very, very common and typically not very problematic. They can be problematic for the woman, but we're not really very concerned about any of these things because they really don't have any severe consequences. Unlike some of the things that I talk about in my other postpartum lectures, namely postpartum hemorrhage, postpartum fever, postpartum psychiatric disorders, which can have some really severe consequences. Okay, so when we're doing our routine postpartum management, that's what we're really looking out for. We're looking out for bleeding. We're looking out for fever. Okay, so that is what we're doing here. And some of these normal findings or complaints are just routine things that occur very, very frequently, if not always, some of these things. Okay, so we're going to talk about shivering, perineal pain, cramping, lochia, hypotonic bladder, and urinary retention, and constipation and hemorrhoids. We'll also briefly talk about breastfeeding. Breastfeeding is something that you want to know some things about, but in most hospitals in the United States, we have lactation consultants, and they are just much better at discussing breastfeeding with patient. I mean, can you imagine me talking to a woman about breastfeeding? I have no personal experience with that whatsoever, although I did read that men can theoretically breastfeed. That's pretty interesting. But I don't ever plan on breastfeeding my children. So I don't ever intend on getting personal experience with this, so perhaps a female lactation consultant, and I imagine most of them are women, would be best. And so we do have lactation consultants, but it's important that you understand some of the ins and outs of breastfeeding so you can have that discussion with your patient. And then discharge and postpartum follow-up visit. Very, very important that all women come in for a postpartum follow-up visit. So the goal of routine postpartum management is to ensure the well-being of the mother and baby and to educate her on how to take care of the child. And like I said, there'll be various agents coming in, lactation consultants, nurses, OB nurses have lots of experience in doing this. So your goal primarily as the provider is to monitor her vitals, make sure that there are no problematic symptoms like bleeding and fever, so that if there are any of those things, that they are managed promptly. Most women are going to remain in the hospital for at least 48 hours postpartum just for standard observation, and during that time the neonate is getting some standard care too. Just workups, looking for any congenital abnormalities and stuff like that. Okay, so typically mom and baby are in the hospital for 48 hours postpartum. A lot of times you can add a day onto that for C-sections, although some hospitals may go a little less than this. Okay, but 48 hours is typically pretty standard. And that may be longer if there are any complications. Sometimes mom may go home before baby if the baby needs to go to a NICU, for instance. There are exceptions, but this is pretty standard. What you're going to be doing while mom is still in the hospital after delivery is you're going to be monitoring her vitals, and two very important things. You want to make sure that her uterus is properly contracted, and this should occur relatively soon after delivery. You should start to have some pretty strong uterine contractions within no more than an hour or so after delivery. And she should be able to void. Okay, now voiding will be a little bit more difficult, but she should at least be able to void. It shouldn't be terribly difficult. We're going to talk about urinary retention in a little bit. Routine labs are typically not warranted as long as the patient is not complicated and she's stable. Okay, so if she has a fever, then yeah, go ahead and get a CBC. Okay, that's fine. But if she's otherwise healthy, uncomplicated, there is no need to get hemoglobin, blood glucose, all that stuff. You don't need to do it. Okay, nature is pretty good at taking care of itself. I like to say that we as doctors don't really do a whole lot other than guide the pregnancy. We're not treating her as much as we're guiding her through the process to make sure nothing goes wrong. But really, nature is taking care of itself. So one of the common complaints that you'll hear very soon after delivery is shivering. Okay, the woman will feel cold, and this is a very common complaint, about 25 to 50% of normal deliveries. And we don't really know why this happens. There are a variety of explanations. That it might be a slight bacteremia, there might be temperature dysregulation, it may have something to do with the placenta, but the pathogenesis is unclear. Typically it begins very soon after delivery, we're talking minutes, and generally doesn't last any more than an hour, 2 hours at the most. Usually this is something that's very, very transient. And so usually by the time we even go to try to manage it, it's already gone away. So the management for shivering is conservative. So something like heated blankets is really all you need to do. By the time you get those blankets to the mom, in some instances, it may already be starting to get better. Now occasionally shivering can be due to anesthesia. So if the shivering, if she received ample doses of anesthesia, if she had a spinal or something like that, you may want to let anesthesia know, because they may want to take some medical steps, because that kind of shivering may last a little bit longer. In those cases, some of the anesthesiologists will give something like meperidine IV, and that will help abate that shivering. That shivering might last a little bit longer. But if it's just regular old vaginal delivery, no anesthesia, or in most cases, even if she does get anesthesia, it's just going to be conservative management with blankets, and it should go away relatively quickly. Perineal pain. Obviously, the woman's going to be in some pain down there. Now, in many instances, she gets anesthesia, but that anesthesia wears off, and then she starts to feel the pain. If you've ever had surgery and you got anesthesia, after you come off the OR, you're feeling pretty good, right? But it's when that anesthesia wears off, that pain starts to creep back up on you, and that will happen with these women when they get anesthesia, and then the anesthesia wears off, they start to really feel that pain down there. And so this is a very common complaint after vaginal delivery. Here we're talking about the perineum, and it's just due to swelling and pain of the perineum. As you can imagine, perineal pain is going to be worse if there are really severe lacerations, or especially if she got an episiotomy. So what do we do to manage this? Again, it's pretty conservative. So we're just trying to reduce the swelling, because that's really the source of the pain. So we'll do some ice packs over the first 24 hours. What that's intended to do is to reduce the swelling, because over 24 hours is when that swelling starts to set in. But then after 24 hours, you don't really have any more swelling. What we want to promote after 24 hours is the drainage of that fluid. And so we don't use ice packs after 24 hours. We'll use heating pads, because that will help the body resorb that swelling, that edematous fluid. Okay, so you can use heating pads. You can also use sitz baths. That's something more long-term. So really just conservative symptomatic management. In many instances, you'll give NSAIDs, like 600 milligrams of ibuprofen. You can give Tylenol, so non-narcotic analgesics. So that can be used for severe pain or pain that just really isn't adequately managed with ice packs. It's pretty standard practice to just give NSAIDs to women if they say they're in pain. Now, if a woman got a C-section, then she's probably not going to have so much perineal pain because she didn't push a baby out her vagina, but she's probably going to have some incision site pain. That pain's a little bit harder to take care of just with packs and pads. So usually you'll throw NSAIDs at that relatively quickly. But another thing that you can do is you can give her, you can do a heating pad if that helps, but you can also give her like a binder around her abdomen. That can help too. So again, with the pain following delivery, it's pretty much conservative management, ice packs, heating pads, and NSAIDs. Okay, so not really a whole lot of drama there. Okay, cramping. Now this is something I want you to pay attention to, because this is where we have a big differential here. So cramping after delivery is very common, and you can imagine what it's caused by. So after delivery, what you have is the baby has come out, the uterus is still large though, and now that uterus needs to contract. It needs to contract, otherwise it's going to bleed. If the myometrium doesn't contract, all those vessels stay open and she starts to bleed, remember? And that's where we run into our problem with postpartum hemorrhage, namely uterine atony. So the uterus will contract, as it should, but that uterus, when it contracts, it can be painful. And so this is what's called after pains. And this will occur up to several hours after delivery until that uterus is fully contracted. A lot of times it's going to be more severe in multiparas, and commonly if you ask the woman, it will occur while she's nursing. So you bring baby into mom's trying to nurse the baby, you get the suckle reflex, and there's a release of oxytocin, and that oxytocin stimulates the uterus to contract, and so that can cause the cramping to coincide with breastfeeding. So the management here, again, it's conservative. This is very self-limited. This is something that goes away on its own. We're not going to do anything for the uterus. We want the uterus to contract, so we're just going to manage the pain. We'll give her NSAIDs. Again, ibuprofen, 600 milligrams every 6 hours. Done. That gets rid of the pain for pretty much all women. This will spontaneously resolve by 1 week postpartum, at the very most. At the very most. In most women, it will resolve much sooner than that. Now, the big differential here is endometritis. Now, endometritis will also give you uterine tenderness, but with endometritis, there will often be a fever, there will often be foul-smelling lochia or discharge, and a lot of times endometritis will coincide with a C-section and or manual removal of the placenta. So that's one thing that you want to differentiate out. If she's complaining about uterine pain, first thing you do, make sure she's not running a fever, and make sure she doesn't have any foul-smelling discharge. But in the majority of cases, uterine pain after delivery is cramping. Okay, ask her if the pain is cramping. What's the quality of the pain? Okay, cramping, uterine pain, very common after delivery, and typically it's just after pains, can be managed with NSAIDs. But make sure you rule out endometritis. Okay, so lochia is really not a complaint, especially if the woman is an experienced childbirther. So if she's an experienced mother, she'll know what this lochia is. And all lochia is it's the basal portion of the decidua which remains in the uterus after placental separation and takes some time, up to weeks, for it to fully expel itself from the uterus. So the lochia will have a different appearance over time. When it first comes out, it's accompanied with a lot of red blood cells, and so we call this lochia rubra, and it's red to red-brown in color. It looks kind of like period blood. Kind of looks a lot like the color of the placenta. Okay, so it shouldn't really be bright. I guess maybe not as much like period blood. It should be kind of a red to a reddish-brown color. But it looks like blood. It really just looks like blood. And that should only persist for the first few days. Gradually, it will begin to lighten in color, and so it should start to turn a more pinkish color, and it's also going to be a lot thinner. Okay, so it's more of a serous consistency, and so we call it lochia serosa, and it's pink in color, and this should last up to about around 10 days postpartum. Okay, and then it starts to turn a more clear to yellow to white color, almost like serum. Okay, just flat out serum. So yellow to white in color, and this lasts up to about a month postpartum, and this is called lochia alba. Okay, so it's not a definite transition, it's a gradual transition from rubra to serosa to alba. What we do know about this is that there only should be about 200 to 500 milliliters total, so not a whole lot. If you have copious amounts of discharge, especially if it's red, it's probably hemorrhage, and then you have a much bigger problem on hand. But this should be just small amounts, and it should never be foul smelling. Okay, so the woman should only know it if she sees it or feels it. If she smells it, this is a big problem. And what is foul smelling lochia a sign of? We just talked about it, endometritis. So this is a really grainy, pathetic picture of lochia rubra. This is the best I could find, though. It looks just like blood. Okay, red to reddish brown, maroon colored. This is lochia rubra, totally normal. But make sure the woman knows about it, okay? Make sure she knows about it. Now with the internet and everything, a lot of women will just find out on their own, but make sure she knows about it so she's not alarmed. Okay, if you start seeing large amounts of a brighter red blood, then you possibly have a hemorrhage on your hand. You want to look for things like a boggy uterus, etc. But this should be a darker red blood, more like a brownish to maroon color. Okay, but it will be thicker in consistency than what you'll get later on. It should start to thin out, though, with time. Okay, so another big problem that we run into is issues with the bladder. So usually a woman will have some degree of difficulty with urinating. It won't be as easy as usual. Some will be harder than others. But anytime there is labor and delivery, and especially if it's a more traumatic vaginal delivery, you can have some neurologic injury, particularly injury to the pudendal nerve. And this can basically stun the bladder, and the bladder really can't empty as it should. It can't contract the way it should. And so because of that, you can have some difficulty voiding. She'll often, though, be able to feel the fact that she has urine in her bladder, and so she'll have some degree of feeling of incomplete voiding. That should say sense of incomplete voiding, not incomplete volumes. So a sense of incomplete voiding. She may have some frequency and urgency. Just the sensation that she has urine in her bladder, but she cannot urinate. And that can be uncomfortable. It really is uncomfortable. If she tries to urinate, she may not even be able to urinate at all. That's a big problem. It may be a very, very weak stream. That occurs in a lot of women where they'll be able to empty their bladder, but it'll just be a weaker stream than usual. Sometimes it may be more difficult. She may need to strain. But if she has real small voiding volumes, or if she can't urinate at all, that's where we get concerned. So anytime she complains that she's not able to urinate, or that nursing tells you we're not getting a lot of urine out of her, the first thing you need to do is get a bladder scan. And that bladder scan is just an ultrasound to check how much urine is in the bladder. So you ask her to void her bladder as much as she can, and then you scan her bladder. and you shouldn't see more than 150 to 250 milliliters of urine in there. And if she can't get enough urine out to where there's less than 250 milliliters left in the bladder, then in that case we need to intervene. Okay, so the post-void residual should be less than 250, but ideally less than 150 milliliters of urine. Okay, so if there's more than that, if there's too much post-void residual, then we need to catheterize her. And we'll do intermittent catheterization, and with time, this will improve on its own. Okay, so we're just going to catheterize her because we don't want her kidneys to be affected. We don't want her to have a post-renal failure, for instance. Okay, that would be a big problem if she can't get her urine out. So we're going to catheterize her for that reason, but with time, this will improve on its own. Okay, so you can discontinue the catheterization once the post-void residual is less than 150 milliliters, and typically she'll know this. Her symptoms have improved. She'll say, I'm able to urinate now, and you'll repeat your bladder scan, and you'll find that the post-void residual has improved. It's below 150, and then you can rest assured that this is fine now. Okay. Now, dysuria, pain on urination, may occur with this or independently from this. So dysuria is just pain, and this dysuria often occurs because of catheterization during labor, and so that can cause some pain in the bladder, pain in the urethra, and so you may have pain but an ability to urinate. Okay, so these are independent. All right, you can have dysuria with urinary retention, but you can also have dysuria without urinary retention, where she's able to urinate, but it's painful. Okay, so if you have dysuria in a postpartum woman, what you want to do first is exclude a urinary tract infection, because dysuria is one of the chief symptoms of a urinary tract infection. So get a urinalysis, exclude urinary tract infection. Once you've excluded urinary tract infection, all you need to do now is treat expectantly. There's really nothing we can do about that. It just needs to heal on its own. What we can do is we can give a urinary analgesic. In many cases we do, just for the woman's comfort. And so one of the drugs that we give out is a drug called phenazopyridine, also known as pyridium. And that's given orally, and once it gets into the bladder, it actually has an analgesic effect, and that will help with her dysuria. Okay, and then constipation and hemorrhoids, very, 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 very common. So constipation, commonly seen due to normal physiologic changes, which include decreased GI tract motility after delivery. Another reason you may see it is if opioid analgesics were given at any point during delivery, which they shouldn't. We try to avoid them, but if they were given, or if opioid analgesics are given after the delivery for some kind of pain-related issue, of course that can cause constipation. Another thing that can cause constipation is if she's not getting up and moving around. And if she's in labor, she's probably not moving around a whole lot. After delivery, she's probably not moving around a whole lot. So there's lots of factors that go in to why she may get constipated. Hemorrhoids develop typically towards the end of pregnancy for vascular reasons, but they can definitely get worse with labor. Because she's pushing. And actually, the more she pushes and the longer she pushes, the more likely she is to get hemorrhoids. And so whatever hemorrhoids are already there are probably going to get worse. And those can become very painful. They can also contribute to constipation, because if it's painful to defecate, you're not going to defecate, that stool is going to get harder, and then you become more constipated. So these things can kind of feed into one another. The management, really, both of these are self-limiting conditions. The constipation will get better over time, the hemorrhoids will remit over time, but we want to be sensitive to our patients, don't we? So what we'll do is we'll make sure that she's getting well hydrated, and then we'll give her stool softeners. And stool softeners will help it make it easier for her to defecate, which will help with the pain from the hemorrhoids, since she's not having to bear down as hard to defecate. And so PO hydration and stool softeners are really at the center of our management for constipation and hemorrhoids. Hemorrhoids can also be additionally treated with sitz baths and topical anesthetics. You can put like a cream on the hemorrhoids in the rectal area, made up of hydrocortisone and lidocaine, which will kind of numb that area, which will make it a little bit more comfortable for her. Of course, all the other things that help with constipation, like getting up and moving around, if you can, trying to avoid pain medications if you can, those are all good as well. Okay, so moving on to breastfeeding. Breastfeeding is, of course, ideal. This is the way nature intended it, and this is what we want if we could pick how mom feeds baby. Breastfeeding is always what we want her to do, with a few exceptions. And that main exception where breastfeeding is contraindicated is if she is HIV positive. We strongly advise against breastfeeding if she is HIV positive. Now there are some other contraindications. Some of them are very rare. Some infections that we basically never run into in the U.S., like brucellosis, never see that here. TB, we basically never see that here, and particularly here I'm talking about active TB, not latent TB. And then some other things that we do see, unfortunately, more common here, like maternal drug abuse, if she's using PCP, cocaine, cannabis. If she's got herpetic breast lesions, so herpes on the breast, we don't want baby's mouth up by that. And then some infant-related issues, like if the baby was diagnosed on their newborn screen with galactosemia, we don't want the baby breastfeeding, we want the baby on a special formula. But in the vast majority of circumstances, breastfeeding is what we want, and breastfeeding should begin as soon after delivery as possible. Studies have shown that 81% of mothers will attempt to breastfeed, but many quit because they encounter problems. And many of these problems can be remedied if they have help. Okay, if they have help from either a lactation consultant or their provider or a nurse or somebody like that. The most common reasons for termination include sore nipples, perception of inadequate milk supply, and concerns that the infant is not feeding properly or is not satisfied. And what we find is that a lot of the mothers who quit breastfeeding are first-time mothers, and they probably don't have a real good idea of how much milk they should be putting out, of if the baby is satisfied or not. And so that's where education really comes in. Okay, when it comes to the sore nipples and the breast pain and stuff, those are cases in which we can help out. Okay, so some of these common reasons are really preventable. Now, there are some risk factors associated with a failure to initiate. So only about 20% of mothers actually don't initiate or fail to initiate breastfeeding. Some out of choice. Some women don't want to breastfeed, and that's fine. We respect that choice, even though we believe that it's not the best choice, we still respect it. But there are some risk factors associated with a failure to initiate breastfeeding. One of those is an African American race. So if they're African American, they're less likely to breastfeed than if they're not. That just underscores the importance of having lactation consultants around for those patients in particular. Young mothers are less likely to breastfeed, particularly under 25. Women who are not married, women who are less educated, women who smoke cigarettes for one reason or another. If the baby was a low birth weight, and what I believe might be behind that is that those babies tend to be in the NICU and away from mom, and that can lead to some slightly impaired maternal-fetal or maternal-infant bonding. Participation in the WIC program, probably because that coincides with low socioeconomic status, which coincides with a lot of these other stressors. Postpartum depression, for obvious reasons, if it was an unwanted pregnancy. And there are some studies out that suggest that there is a decreased failure to initiate if there was a cesarean delivery. Okay, so breastfeeding education, as I've mentioned already, should begin before delivery, and lactation consultants and educational material should always be provided. Very, very, very important stuff here, because if mom wants to breastfeed but she doesn't know how and then she quits, that's on us. That is definitely on us. So we should encourage mom to breastfeed while she's in the hospital, if it's possible, every 2 to 3 hours while she's awake. And the reason for that is because it helps stimulate milk production, and we want to get that going as quickly as we can. So discharge instructions. Typically we discharge mom around 2 to 3 days postpartum. We want to try to get those appointments for postpartum follow-up as well as for baby's pediatric visits scheduled before she leaves, because if we wait until after, she may not do it, especially for her. She may do it for baby, but not for her. So we want to get that scheduled as quickly as possible. RhoGAM should be given to all Rh negative women of Rh positive babies within 72 hours of delivery to prevent complications in future pregnancies. We want to administer all vaccines that she needed but couldn't get in pregnancy. So for instance, if during pregnancy we found out she was rubella antibody negative, we can't give her a rubella vaccine during pregnancy, can we? But we can give it to her now. We don't want to wait. We don't want to wait until later. We don't want to say, oh, just come back at your postpartum visit. She might not come in for a postpartum visit. We don't want to tell her, oh, come in and get your rubella vaccine eventually. Because what happens? She doesn't, and then she gets pregnant, and then now she's rubella negative, and that baby is susceptible to possibly getting congenital rubella if she's exposed to rubella. So what we want to do is we want to give her rubella vaccine before she leaves that door, so that when she gets pregnant in the future, we won't have that problem on hand. We want to tell her to come in. Either come see her OB or her provider, or go to the ER if there are things like significant bleeding, okay, postpartum hemorrhage, fever, new or worsening perineal pain. That pain should get better, not worse. If it gets worse, we worry about possible dehiscence of the sutures where that wound is, or possibly an infection. Dysuria, UTI, breast problems, leg pain or swelling, significant mood disturbances, postpartum depression. We're always very worried about that. And severe headache. Why severe headache? What are we thinking about there? Eclampsia, preeclampsia. It can happen after delivery, believe it or not. So you can get preeclampsia and eclampsia after delivery. So that is something we want to make sure that she comes in for as well. It's okay to resume activity as tolerated in most cases. However, women who've had a cesarean section should try to avoid heavy lifting for about a month afterwards, and oftentimes they need to avoid the seat belts, the car seat belts, because of their wound. But for the most part, they can resume activity as tolerated in most cases. Okay, intercourse is okay as long as there's no bleeding. So as long as she's, and don't confuse lochia with bleeding. So as long as she's not having active oozing bleeding coming out her vagina, intercourse is okay. A lot of women aren't going to want it because they're still in some pain. It will take some time before they want to have sex again, but you can tell her that intercourse is totally fine as long as you don't have any bleeding and you're comfortable with it. But on that note, ovulation may occur as early as 25 days postpartum. So you need to have some kind of contraception plan before she leaves the hospital if she wants that. Some women are, well, if I get pregnant, I get pregnant. That's fine. But she needs to know that ovulation can occur very soon after. Typically, she's not going to menstruate for about 4 to 6 months postpartum. But that can happen very soon. Okay, so she needs to know that, and you need to have some kind of contraceptive plan. You can't do oral contraceptives if she's breastfeeding. The reason for that is that the estrogen can suppress milk production. Usually we'll go with the mini pill, the progestin-only pill, and she'll take that. That's good. It's good for breastfeeding. It's pretty good for suppressing ovulation, so we'll do that. We can't put the IUD in until 6 weeks postpartum. So usually we go with the mini pill, in rare cases, Implanon or Depo-Provera. Okay, and then the postpartum visit. The postpartum visit is usually scheduled within... Okay, and last but not least, we have the postpartum follow-up visit. Very important because all women need to come in for a postpartum follow-up visit. Now, as I said, we like to have that visit scheduled in advance, but we want to see all women at about 6 weeks after delivery. Now, there are some women we may want to see sooner. So one big group of those women would be the women who had C-sections. We want to look at their wound to make sure that it's healing properly. Women who had more complicated deliveries may be seen sooner. If they have any particular concerns, they may be seen sooner. But we want to see all women at about 6 weeks postpartum because there are important things we need to talk about and some things that we may need to do or may want to do. Okay, so some things that you'll want to bring up are the health of the infant. We want to know how baby's doing. We want to know how mom is doing. Why do we want to know how mom is doing? Because one of the things that can seriously go wrong after delivery is postpartum depression. And we screen all women for postpartum depression, no matter what. All women are screened for postpartum depression. Now, sometimes they may come in with symptoms, especially if you told them. If your mood starts to get in the way of things, come in. Please come in. But at 6 weeks, we screen all women for postpartum depression. And what we do is we just give them this little handout. It's a little questionnaire they fill out called the Edinburgh Postnatal Depression Scale. And they fill it out, and we look at it and see if they are at risk for postpartum depression or if they have postpartum depression, and then we can intervene. And I talk about postpartum psychiatric issues in another talk, but what we'll do is we'll do psychotherapy and SSRIs for postpartum depression. Okay. We also want to know about her contraceptive plan. Now, some women are, well, if I get pregnant, I get pregnant. And that's fine if that's what she wants. But what she needs to know, and what a lot of women don't understand, unfortunately, is that breastfeeding, while we love it, breastfeeding is not a reliable means of contraception. Okay, now, it is true that it will reduce your risk of getting pregnant. If you want to get pregnant, then breastfeeding may get in the way. But it is not a stopgap. Okay, many a woman has gotten pregnant while breastfeeding. So we want to know what her contraceptive plan is. Because if she tells you, well, I'm breastfeeding, that's my contraceptive plan. No, you need something else. Now, when we sent her home, if she wanted some kind of contraception, our hands were kind of tied. We couldn't give her the pill if she was breastfeeding. I mean, when I say the pill, I mean the combined oral contraceptives. We couldn't do an IUD because there's an increased risk of expulsion after delivery. And so our hands were tied, and pretty much all we could do for her was the mini pill or the Implanon or Depo-Provera, etc. Barrier contraception. However, at 6 weeks, it is now okay to do an IUD. And IUDs are very popular. They're very low maintenance. And so if she wants very good, reliable contraception and she doesn't want to take a pill anymore, then we can put in an IUD at this point. And now would be a great time to do it. We can ask her about her return to sexual activity, primarily because we want to know about her contraceptive plan, and then any difficulties with breastfeeding. Because if there are difficulties, we want to set her up with a lactation consultant or groups, or provide her with the quality patient education that she needs to continue breastfeeding. Because we're always worried about cessation of breastfeeding, that she will terminate breastfeeding because she doesn't feel that she's doing it properly. And so if we can educate her and get her to understand what she needs to do and what's appropriate, then we can reduce the number of women that terminate breastfeeding before they want to terminate it. We want her to be breastfeeding as long as she wants to. We'll also address any complications that may have occurred during the pregnancy. Chiefly here, I am talking about gestational diabetes. So at 6 weeks, all women with gestational diabetes should get the oral glucose tolerance test to ensure resolution. So it's that 2-hour, 75-gram oral glucose tolerance test. The diabetes should be gone at this point. If it's not gone, then we start to worry about type 2 diabetes, just plain old garden variety type 2 diabetes. And then the physical exam. Always get a good physical exam on these women. Check her vitals, check her thyroid, check her breasts, look for any fissures, tenderness, lumps, skin changes in her breasts. Palpate and look at her abdomen. We're looking here for hernias, diastasis recti. Look at the external genitalia. Here we're looking for wound healing if she had a laceration. We're looking for fistulas. We want to feel her vagina. We want to check out that pelvic support. We don't want there to be any prolapses. And then we'll check her cervix, uterus, and adnexa, looking for what we normally look for when we do pelvic exams, namely the size, if there's any tenderness, or if there's any masses. Okay, so a good, well-woman physical exam is good to do postpartum. Okay, and with that, I don't have anything else to add. So if you have any questions, please write me a note below. Otherwise, I will see you next time.